6 surgeons and an internist discussed the indications and contraindications, aggressive versus conservative approaches to surgery of the thyroid for nodular goiter, thyroiditis, carcinoma, hyperthyroidism on Audio Digest Surgery, Volume 18, Number 18, for the week of September 22nd, 1971. And starting this information pack 60 minutes right off, our program moderator, Henry Sosine of the University of Minnesota Medical School.
Dr. Bears, who is professor of surgery and head of a section of surgery at the Mayo Clinic, is going to address himself to the subject of nodular goiter.
The discrete nodule, firm in a young patient, obviously is the type of nodular goiter that should be removed surgically. A solitary nodule should be removed, but a multinodular goiter, which has parameters suspicious of being malignant, should also be removed. There are other hazards to a nodular goiter than cancer, the cosmetic appearance. For cosmetic reasons, a large nodular goiter should be removed. Also, pressure symptoms in the neck, causing pressure on the airway or the vascular supply at the thoracic inlet, is an indication to remove a nodular goiter, and marked deviation of the trachea or other structures likewise indicate thyroidectomy. Now, the thyroid scan is one test which is of value in trying to determine whether or not a nodular goiter should be removed. Now, in one study in which we reviewed a group of cancers that had scans, 60% of the scans had cold spots related to the area of the nodule which proved to be cancer. However, 34% of the scans were essentially normal, and in 6% of the scans there was an area of increased uptake in the area of the nodule. I cite this only to indicate that a scan with a cold nodule certainly should make one seriously consider thyroidectomy, while a scan which is either normal or has a hot spot should not rule out the fact that the lesion could be a surgical lesion if there are other parameters that are important. I would like to review the parameters that one should think of in considering a nodular goiter for removal. One is age. Hales has shown that 50 to 70% of nodular goiters in children prove to be malignant. Recently, a study carried out by Thorvaldsen, 61% proved to be malignant. In the adult population, this is much lower. Exactly what it is, I don't know, but let us say 1% of clinically significant nodular goiters seen in the office might be cancer. It might be higher than that, it might be less than that. But anyway, age is important, sex is important. There are more thyroid cancers in women than in men, but percentage-wise, the incidence of cancer in men in nodular goiter is greater than women. Therefore, a nodular goiter occurring in a man should be more seriously considered surgical than one in a woman. Duration of the goiter, if it's of recent origin, if it's new, if it's not been known to exist previously, it's more important to consider removal than if the goiter has been known to be present for a period of years. Historical facts are important. Now, we know that goiter runs in families. We don't know necessarily that cancers run in families, except that we do have some information that possibly medullary cancer does. Therefore, if there are any family factors that are important, these should be considered. In a youngster, if X-ray had been given to the head and neck area at an earlier period of time, then this becomes important. Physical factors, single versus multiple. A single nodular goiter more often should be removed than a multinodular goiter, but you must remember that a multinodular goiter doesn't mean that cancer can exist. Consistency. One that is firm and hard more likely should come out than one that is soft and cystic. But again, a papillary lesion can be cystic at times. Certainly, extranodular thyroid tissue does not rule out the chance that coexisting pathology can exist in a Hashimoto's thyroiditis, for instance. And then, naturally, if there's lymphadenopathy in the lateral neck, this becomes important in determining whether or not a nodule felt in the thyroid gland should be removed. I made reference to the scan already. Most often, a cold nodule should come out, where a hot nodule should not necessarily be removed. And finally, I think one must recognize that if you're going to do prophylactic thyroid surgery, your surgical experience should be such that the risk of thyroidectomy is extremely small, certainly much less than 1%, probably closer to 1/10 of 1%, and the morbidity of thyroidectomy should likewise be extremely small, where the more significant morbidity is less than 1%. Finally then, any goiter, solitary nodular goiter in a young patient of recent origin, feeling firm and hard, cold on scan, certainly should be removed. On the other hand, a woman in the older age group with a multinodular goiter, soft and cystic, which has been present for many years, asymptomatic otherwise, certainly can be observed. And I think it's up to all of us to use the parameters available to us to select the nodular goiters well, so our experience, both in the management of the patient and the mortality and morbidity of the surgical treatment, have excellent features.
Our next speaker will address himself to a topic to which Dr. Beers already alluded, that of thyroiditis or a non-malignant pathology of the thyroid gland. Our next speaker is Dr. William McConaughey. He's professor of medicine at the Mayo Clinic and member of the Department of Endocrinology there. Dr. McConaughey.
Today I want to talk with you about 4 separate and distinct diseases of the thyroid gland. These are all called thyroiditis, but there are 4 different diseases actually. In my opinion, there are 4 and only 4 types of thyroiditis. 2 are quite rare, these being the acute suppurative and Riddell's thyroiditis. 2 are more common, being subacute and Hashimoto's thyroiditis. Now, acute suppurative thyroiditis is extremely rare and actually is only an abscess of the thyroid gland. It is sometimes, however, associated with thyroid carcinoma, which should be remembered, and sometimes with general sepsis. Like any other abscess in the body, it should be treated with antibiotics and with incision and drainage. Now, the second type of thyroiditis, Riddell's thyroiditis, is also extremely rare. This occurs supposedly once in every 2,000 thyroidectomies, and we see it at the Mayo Clinic about once every 2 years. So certainly it's not very common. It's a progressive disease in which the gland is replaced by dense fibrous tissue. The etiology is unknown, but it may be related to the retroperitoneal fibrosis, which has been described in the abdomen. When it does occur, it may be a more generalized disease than just in the thyroid alone. Now, this is not a malignant disease, but it does invade the adjoining tissues and becomes fixed in the neck. Because these lesions are extremely hard, they can't be differentiated by palpation from thyroid cancer. And so usually surgery is necessary to make a diagnosis and often to release the constriction around the trachea, which may occur. At the time of surgery, usually all that's needed here is the isthmus division to relieve the tracheal constriction if the disease is bilateral, or if it is unilateral, simply a resection of the affected lobe. The prognosis after such surgery is excellent, for recurrence is almost unknown, and the disease seems to stop progressing once the constriction of the trachea has been released. Now, whether hypothyroidism develops will depend upon whether the amount of thyroid tissue destroyed was great or small. The third type of thyroiditis is subacute thyroiditis, also called acute diffuse thyroiditis, decurving thyroiditis, or granulomatous thyroiditis. This is not at all uncommon. This is a self-limited disease thought by many to be a true inflammatory disease related to a virus or caused by a virus, but just what virus is unknown. It may last from a few weeks to many months. It may present a variable picture from one with no symptoms whatsoever to a very severe prostrating illness. There may simply be a painless lump or a small lump with a few symptoms, slight tenderness, a little malaise, slight ache in the joints, in the jaws and ears, or it may present with very severe symptoms of high fever, up to 103, symptoms of extra tenderness in the neck, prostration, and symptoms of hyperthyroidism due to the breakdown of the thyroid parenchyma and the discharge into the circulation of thyroid hormone. This will then produce a picture of hyperthyroidism in such patients. There are two laboratory tests which will clinch the diagnosis: the sedimentation rate and radioiodine uptake. In the typical case, the SED rate is high, being 80 or more in many patients, and the radioiodine uptake in a typical case is nil, because the thyroid gland is so disrupted that little radioiodine will be collected by the thyroid gland. The treatment of this disorder is none if the symptoms are mild, salicylates if they're a little bit more severe, and steroids if they're very severe. If steroids are given, they should be given in large doses, for example, 10 milligrams of prednisone every 6 hours to begin with, and this is very effective in stopping disease progress in a day or so. The gland will become non-tender in 24 hours, disappear from the palpatory stage in about 3 or 4 days, and decrease in size very quickly. One should then, of course, decrease the dose of prednisone as fast as he can and finally taper it off when the symptoms will disappear. However, as long as the patient has symptoms and steroids have been given, one must keep up the steroids in small doses until the gland returns to normal. As said before, it's a self-limited disease, so no treatment is necessary in the mild cases. Now, surgical removal of the thyroid gland, use of antithyroid drugs and thyrotropin, the administration of X-ray treatment to the thyroid have been advocated in the past, but are seldom used now. The effect of steroids are so good and so predictable that no other treatment is needed in severe cases. This disease is self-limited, and steroid therapy simply masks the symptoms until a patient gets over the disease by himself. Permanent myxedema following subacute thyroiditis has been reported, but it's extremely rare. Usually recovery is complete. But since myxedema can occur, patients with this disorder should be followed for some period of months after the disease is cleared up in order to make sure that they don't develop myxedema. Finally, to turn our attention now to Hashimoto's thyroiditis, also called lymphocytic thyroiditis or stromal lymphomatosa. This is much more common now than it used to be. I think that for some reason unknown to us, Hashimoto's thyroiditis is indeed on the increase and is seen as a very common thyroid disorder at the present time. Nobody knows really what this disorder is, but apparently it is an autoimmune thyroid disorder. The clinical diagnosis may be difficult or may be simple, but usually its clinical classification is not too difficult. It occurs usually in women. It occurs at nearly any age from 8 to 80. The average size goiter occurs. These are usually not large thyroids. They may be firm and bossulated, but not really nodular. They're diffuse. They usually have no gross nodules. Hypothyroidism is not uncommon. And in my book, a patient with hypothyroidism and a goiter in a woman with Hashimoto's thyroiditis will prove otherwise. The BMR is usually low. The radioiodine uptake can be high because the gland is making many non-chlorogenic iodinated proteins, which are put out in the blood. And the PBI, BEI have a difference, which is strikingly large, because these iodinated proteins, non-chlorogenic substances, which the gland puts out, are measured as PBI, but not as BEI. So this difference is quite striking. Now, I rely on the histologic appearance of the thyroid tissue for proof of the diagnosis of Hashimoto's thyroiditis. And this is usually obtained by thyroid needle biopsy done by our thyroid surgeons. Until recently, such diagnoses were difficult because of the great disagreement among pathologists as just what Hashimoto's thyroiditis was. However, Woolner has classified the picture and clarified the picture considerably, and almost all thyroid pathologists now agree with his classification of Hashimoto's thyroiditis. Wooler has shown that the pathologic picture described in 1912 by Hashimoto and sometimes called true or classical Hashimoto's is really only one variant of this autoimmune thyroid disorder. His classification first is lymphoid Hashimoto's, where the lymphoid tissue predominates. Second is oxyphilic Hashimoto's, with the oxyphilic tissue present. His third type is hyperplastic, with much hyperplastic tissue present. The fourth type, fibrotic, with a lot of fibrosis present. And finally, number 5, the focal thyroiditis, with normal thyroid tissue and many, many nests of lymphocytes around the thyroid. Now, all of these 5 different types are really Hashimoto's thyroiditis, but they differ in appearance. As I said before, almost all thyroid pathologists now agree that these indeed represent the same autoimmune thyroid disorder called Hashimoto's, or lymphocytic thyroiditis. Now, our thyroid surgeons have done well over 600 thyroid needle biopsies as an office procedure with no major problems. The surgeons use the Franklin modification of the M-silverman needle for their thyroid needle biopsies, and usually the tissue removed is very good. The treatment of Hashimoto's thyroiditis is simply thyroid hormone. Most goiters will then either go away entirely or at least get smaller. It rarely requires surgery. Occasionally, if the gland is huge and does cause obstruction, or if the diagnosis is in doubt, then thyroid surgery is used. Unsuspected cancer in Hashimoto's thyroiditis is no problem, so surgery is rarely needed to rule out cancer. Now, only if the gland is found to have true nodules, as occasionally happens, do we worry about thyroid cancer and then wish for surgery. But usually, if the gland is symmetrical inconsistency, one can be quite sure that thyroid cancer is not present and surgery is not needed. If single nodules are noted, we then do call our thyroid surgeons in.
Our next speaker comes to us from Chicago. Dr. Kaplan is an assistant professor of surgery at the Pritzker School of Medicine at the University of Chicago. He's going to talk to us about medullary carcinoma of the thyroid.
Medullary carcinoma of the thyroid was recognized as a separate entity in 1959 by Hazard, Hawk, and Cryle. A great deal of interest in these tumors has been generated because pathologically, physiologically, and clinically, they differ from other thyroid neoplasms. They are the only thyroid tumors which contain amyloid. The characteristic feature, which is diagnostic of medullary carcinoma, is the finding of amyloid, which may be demonstrated by staining with Congo red, methyl violet, or thioflavin T. While appearing undifferentiated, they have a much better prognosis than anaplastic carcinomas of the thyroid. They are the only thyroid neoplasms which may be familial as well as sporadic. At times, this tumor is part of a syndrome of lesions termed multiple endocrine neoplasia type 2. Finally, these tumors are endocrinologically active and secrete calcitonin, serotonin, prostaglandins, and/or an ACTH-like substance, singly or in combination. Most frequently, medullary carcinomas present as single or multiple neck masses. Hoarseness, dysphagia, or symptoms of systemic spread may be prominent. In some patients, however, flushing and diarrhea may be severe. Symptoms of Cushing's syndrome or hyperparathyroidism may be prominent. An inherited familial syndrome has been described, which Steiner and associates have coined the multiple endocrine neoplasia type 2 syndrome. In its complete form, it consists of medullary thyroid cancer, which is associated with pheochromocytomas, mucosal neuromas, and hyperparathyroidism. Most individuals with the inherited medullary carcinoma syndrome have no changes in their physical appearance, but several have been reported to have long extremities, fingers and toes, pectus excavatum, kyphoscoliosis suggestive of Marfan's disease. In 1961, Sippel demonstrated an increased occurrence of thyroid cancer with pheochromocytomas. The thyroid cancer was found to be medullary carcinoma, and this association has often been referred to as Sippel syndrome. However, this combination may be part of the multiple endocrine neoplasia syndrome. There are some unusual things about these pheochromocytomas. One is a high incidence of bilaterality, 70%, as opposed to the 8% usually found with pheochromocytomas. They are often multicentric within the same gland. There is no difference in the incidence of malignancy. However, there is a very low incidence of sustained hypertension in this group. Without medullary cancer, about 2/3 of pheochromocytomas have sustained hypertension. With medullary cancer, only 6% do. There's an increased incidence of parathyroid abnormalities have been present in association with medullary carcinomas of the thyroid. The work of Dr. Tastian and associates from Boston shows that overall 38% of people who have medullary carcinomas in which they studied had high parathyroid hormone concentrations in the serum. The thyroid tumors all have high amounts of calcitonin within them. Tumors contain from 650 to 16,000 times more calcitonin than is found in normal thyroid tissue. Again, in the serum, patients with medullary carcinoma have very high levels of calcitonin, and this can be found both by bioassay and by radioimmunoassay. By doing a calcium infusion, it has been demonstrated by raising the calcium concentration in the serum, one gets a marked rise in calcitonin in the serum, and this can be, again, very easily demonstrated by bioassay. And the techniques are not hard. Finally, a few words about treatment. We favor an aggressive surgical approach to this disease because treatment with thyroxine, radioactive iodine, or external irradiation is generally ineffective. When tumor is limited to the neck, we feel that a total thyroidectomy should be performed with unilateral or bilateral node dissection if the nodes are involved. In patients with metastatic disease who suffer from diarrhea or flushing, removal of as much thyroid mass as possible is appropriate, since significant palliation may be achieved.
It's my job to try and cover some information about anaplastic carcinoma of the thyroid. And when you attempt to go to the literature to find some information, you find that the results are so horrible that nobody wants to have their name associated with it. Unfortunately, then, there's precious little information about this disease. There is some difficulty in definition when you talk about anaplastic carcinoma. I think to many pathologists it means undifferentiated. In older series, it also included diseases that you just heard about, medullary carcinoma or solid adenocarcinomas. Specifically, then, I think that if you talk about anaplastic or undifferentiated carcinoma, you're talking about carcinomas which exclude papillary, follicular, mixed, medullary, and Hürthle cell tumors. And you're left with a very aggressive group of tumors that we call anaplastic or undifferentiated. Now, fortunately, the incidence of this lesion is extremely low. Lindsay found only 5% of his collected series with this disease. At the Mayo Clinic, you already heard that they're reporting 14% of their total series, and another series reports 11%, so that the overall incidence of this particular type of disease is probably around 10%. Despite the fact that it's an infrequent lesion, when you encounter it, it causes a significant amount of death which is caused from thyroid cancer. In Silverberg's study, where he specifically studied patients who died of thyroid cancer, it accounted for 42% of those patients. In another similar study by Ibanez, they found 1/3 of their patients dead of cancer died from anaplastic disease. So this is a disease of advanced years. A paper by Hallman indicates that differentiated tumors, the prognosis decreases markedly as the age increases, and this is also true for undifferentiated tumors. Advanced age means bad prognosis in this disease, and of course the undifferentiated character of the tumor means bad prognosis. The sex ratio in thyroid cancer is generally considered to be greater in the female. Of collected series, you could assume that maybe slightly more than half, 55 to possibly 60% of the patients who have anaplastic tumor will be female. These people present with an extremely simple and straightforward presentation. They usually will present to you with a mass with recent enlargement. And this recent enlargement I mean by 1 to 2 to 3 months. We've had 24 patients that I've been able to find the records of. Over half of them presented with the symptom of hoarseness, and well again, over half of them either had dysphagia or stridor. These symptoms usually occur within a 3-month period prior to the time they are seen. Of significance, over a third of these patients have had long-standing prior enlargements of the thyroid gland. The mean time of symptoms prior to the time that they were seen at the hospital, in our experience, was only 3.5 months. Now, these people are clinically most often euthyroid. If you do a BMR or a PBI or a T3, you'll find them normal. Small groups of these patients, only 8 of our own, did have iodine uptake studies done, and most of them, 6, had depressed uptake. And this is true of the other reported series where iodine uptakes have been done. In addition, if a thyroid scan is done on the mass, they most all are cold. Now, of importance is the extent of the disease at the time you find them. 80% of these have direct gross extension into the neck, either to the esophagus, the trachea, the strap muscles. The mass is usually quite large, very firm, and fixed. Half of these patients have distant metastases at the time that they present to you. 10 of our patients had metastases demonstrated by chest x-ray with multiple pulmonary metastases. In our own experience, 11 patients had nothing done but biopsy. 9 patients underwent a palliative excision, and the 2 patients that were thought to have intrathyroidal disease underwent what was thought to have been a curative resection. This was, in one patient, a subtotal thyroidectomy with postoperative x-ray administered. That patient survived only 6 months from treatment. In another patient, total thyroidectomy was done, a left radical neck dissection, and also followed by post-op x-ray treatment. That patient survived 3 months from treatment. 19 of the patients received radiation. That was either in the postoperative phase or as primary treatment following a biopsy. Now, 3 of these patients died what I called an operative death. Actually, one of them died following a laparotomy for diffuse disease. The laparotomy was done in an attempt to make the diagnosis. The diagnosis was made at post-mortem when a small intrathyroidal tumor was found. The mean survival from the onset of symptoms is only 6.7 months, and the mean survival from treatment is only 3 months. All of these patients died of their tumor. The longest survival in our own limited experience is 11 months, and that particular patient only had a biopsy and post-biopsy x-ray. 79% or 19 of these patients were dead within 6 months, and all were dead within 1 year. I want to take just a moment to mention one other thing, and that's transformation, which is thought to be an important aspect of this disease. All patients who die with anaplastic lesions probably did not have anaplastic lesions originally, and the thought is that patients with long-standing papillaries or hurdle cell lesions or folliculars may at some time in the future, the tumor may digress and become anaplastic. And this has been demonstrated pathologically, both from the series, the Mayo Clinic. 2 of our own patients demonstrated this type of change, and this is noted in every paper that has dealt into this subject.
And this is the end of Side A of this program, Doctor. Side B can be heard by just flipping over the cassette or 2 reels on your tape recorder. Side B, Audio Digest Surgery, Volume 18, Number 18, continues a program on surgery of the thyroid. And here again, program moderator Henry Sosine.
Our next speaker, Dr. Richard Jesse, is professor of surgery and head of a section of head and neck surgery at the MD Anderson Hospital in Houston. And he's going to talk to us about the radical treatment of carcinoma of the thyroid gland. Dr. Jesse.
In the late 1940s, the advent of radioactive iodine prepared the way for a new outlook for the treatment of thyroid cancer. The greatest potential of I-131 in the treatment of cancer seemed to lie in its ability to reach metastatic deposits. Since the MD Anderson Hospital at that time was a young, struggling hospital looking for a happening, and since an aggressive internist was on board and was interested in radioactive iodine as it related to thyroid cancer, this became MD Anderson Hospital's thing. And it soon became evident, however, that normal thyroid tissue utilized the iodine much more efficiently than did abnormal thyroid tissue. And if any normal gland remained after thyroidectomy, it competed with the metastasis for the I-131. And the I-131, therefore, did not reach the metastasis. And the internist got the idea that if all the normal gland could be removed, perhaps by letting the patient become hypothyroid and under the stimulation of thyroid-stimulating hormone, the metastasis could then be made to concentrate enough of the I-131 to destroy itself. He therefore came to the surgeon, and I might say this is a rare switch, and begged us to do total thyroidectomies. And this concept therefore stimulated the total thyroidectomy program at our hospital, a practice which continues today. About this same time, the pathologists in our hospital were also looking for a happening, and since total thyroidectomy was being practiced, it gave them an opportunity for the first time to determine the true nature of the malignant process throughout the gland proper and in its immediate zones of dissemination. They sectioned the whole organ at 50 micron levels and mounted these on big glass slides. Therefore, a three-dimensional representation of the gland could be studied. And in 116 glands that have been studied by this method so far, 78% of the group had cancer extending into the isthmus, the opposite lobe, the pericapsular lymph nodes of the opposite side, or to more than one of these areas. In many cases, this type of spread could not be appreciated either clinically or at the time of surgery, or sometimes even after the gland was removed and examined grossly. Because these whole organ studies showed cancer outside the lobe of original involvement, and because we do not know how to interpret the significance of these findings, we continued to do total thyroidectomies. Since we now have found out why we do aggressive surgery, let us define it. The minimal procedure done for thyroid cancer at our institution is a total extracapsular thyroidectomy with the removal of all the pericapsular nodes. And we also do what we call a compartmental dissection. This removes all of the lymph nodes from one jugular vein to the other jugular vein, as high as the origin of the superior thyroid artery. And it includes a dissection of the upper mediastinum down to and including the thymus gland. The strap muscles are always divided in their upper 1/3 to give adequate exposure. We make a heroic attempt to identify and preserve the contralateral parathyroid gland. Now, this is the minimal procedure, but to this procedure, if indicated, we add removal of the strap muscles, a partial or classical radical neck dissection, and in a very, very few instances, a sternal splitting incision. As you can see, therefore, our usual practice removes the pericapsular nodes, which in our experience are the first-line nodes which become involved in thyroid cancer. It also removes the nodes immediately laterally along the jugular chain, and it removes the nodes in the superior mediastinum. The lateral neck is not disturbed unless there is gross disease lateral to the vein. Neck dissection is either done in a classical manner, or more commonly, it is modified by dividing the sternomastoid muscle in its lower third, usually a centimeter over the sternum, and putting it back superior laterally, preserving the 11th nerve, which can be done very nicely, and then at the conclusion of the procedure, sewing the muscle back. This prevents any trouble with either cosmetic problems or with shoulder drop incident to the loss of the 11th nerve. If the lateral neck has many positive nodes in it, we also explore the retropharyngeal node of Rouvier, because we have found that these nodes have been positive on 2 or 3 occasions when the lateral neck nodes are also full of tumor. The modification of the classical neck dissection rarely compromises our ability to remove the nodes, and the cosmetic effect far outweighs, we believe, the little bit extra time that it takes to do it this way. Now, the major objection to total thyroidectomy as practiced at our institution has been the production of permanent hypocalcemia. 13% of the patients had what we call permanent tetany, and this is defined as a patient who needs calcium or D2 1 year after his thyroidectomy. Therefore, there are 54 patients. And what kind of disease did these 54 patients have? 17 of them had disease in one gland only, whereas 37 of them had regional nodes involved and required a bigger operation. And in only 10 of the 54 patients was there cancer in only one lobe. And so we think that perhaps this is the type of patient that will get permanent tetany. What kind of surgery produced this complication? There was no attempt to locate the parathyroids in 18 patients, but in all the rest of these patients, some sort of technique was done in which we thought we had saved parathyroid tissue. And either we don't know parathyroid tissue when we see it, or we ruin its blood supply and knock it out, because in these patients, they did develop permanent tetany. Now, we did a workup on all of the patients with permanent hypoparathyroidism. And here's the interesting thing. Patients will start with a low calcium, and these are patients on treatment. But they'll start with a normal calcium at the time of surgery. They'll dip down at 6 months, and then slowly they'll go up. At a year, nothing much will happen. Their calcium will still be low. But if you follow them long enough, most of these patients will go back to having a normal calcium. All our patients who have hypocalcemia are put on D2, 50,000 units once or twice a day, and probably about 10 grams of calcium lactate or something like that. And you can overshoot these patients when the parathyroid glands recover. Finally, the only abnormal factor, really, the only thing that disturbs us a little, 11 patients out of the 54 who had spike foci and fast activity in their EEGs. Our neurologists don't know what this means, and we don't either. There are only 2 patients in the whole group who had convulsions. Now, are we going to try to change our policy of total thyroidectomy? We're not going to change it for another 5 years, when we should have, at that time, 1,000 cases in which will give us pure data in time. Have we learned anything that might make us think of modifying our stand in some future date? Are we getting sophisticated enough so that we can separate out a group which might not need total thyroidectomy or might not need such aggressive treatment? As the previous speakers have shown, if disease is confined to the gland in the differentiated groups, your prognosis is good. If it's in the regional nodes only, it's still pretty good. These 2 groups could probably be treated with a little less aggressive treatment, whereas if it's in the invasive or remote area when you first see the patient, then it's not so good. And this group still must be treated aggressively. Similarly, what the previous speakers have alluded to, the 10-year survival rate in people less than 40 years of age is still up around 96%, whereas patients who are in the older age group, 40, 50, 60, 70, 80, fall off and get in trouble with their thyroid cancer. Perhaps, therefore, we could modify our position in the young age group and not do as an aggressive procedure there. We are a cancer hospital, not a general hospital. We don't know how to treat this disease, but it seems to us inconceivable that surgeons will leave cancer in the neck of patients when they know it exists. We don't know what the high percentage of disease in the contralateral lobe means yet. We don't think that permanent tetany, as we define it, only having a very small number of patients who have permanent trouble, is necessarily a deterrent. The data on this disease is strange. There are many, many variables, and until we have much more pure data in which the mixture of variables is subject to analysis, we'll rest our case on the aggressive treatment.
Our next speaker, Dr. Kreil, is going to speak to us about a more conservative approach to treatment of thyroid cancer. Dr. Kreil.
When you really classify thyroid cancer and use a certain terminology, you find yourself in agreement with any clinician that you speak to about it. The great controversy of thyroid cancer and how to treat it arises because people simply aren't using the same terms to define what they're talking about. And I must say that I was very much interested in Dr. Jesse's remarks, and I'm sympathetic with the experiment, and I think it's justified in the amount of knowledge that they have gained. But I don't believe that any statistician could support a form of treatment as a permanent adjustment after you've learned what you can, which induced a morbidity, even though it's not a serious one, but tetany does have its complications. And I admire very much the way they've modified their neck dissections so that they no longer cause the deformities that they did. And all of this shows a trend towards differentiating within the group of papillary cancer, say, and towards perhaps in the younger group where mortality is nil in practically everybody's hands, no matter how treated. In these people, it certainly seems that the principles of cancer surgery can be forgotten because in these younger people, the papillary cancers behave very much more like endometriosis, for example, than they do like endometrial carcinoma. It's a different type of almost non-malignant disease. Now, with this introduction, I'd like to go through treatment almost in support of what the Mayo Clinic group have said. See, we're using the same classification. Papillary, which in the young people is practically benign, and the follicular is very bad in our hands, just as it is at the Mayo Clinic. The medullary, terrible if there are nodes involved. Sooner or later, most of these people die, although it may take them up to 20 years to do so, but good if they're not. Anaplastic, we have uniform fatality with one exception. One person many years ago was treated by a palliative subtotal removal of the tumor, followed by 250 kV, totally inadequate radiation. Patient has remained well. The slides have been reviewed. There's a possibility that it could be a lymphoma, which probably it is, although they still classify it as a small cell anaplastic carcinoma. Mayo Clinic has only 1, 2 in their vast experience. So anybody who says that they are curing any number of anaplastic carcinomas of the thyroid is classifying them differently than we are or the Mayo Clinic is. Now, this is the typical appearance of the papillary carcinoma that I'm going to spend most of my time speaking of. It has no beginning or end. It is an infiltrative thing. It's like a serous carcinoma of the breast. You can't enucleate this nodule. That's why the papillary carcinoma has a characteristic feel. It doesn't feel like a thyroid nodule. It feels like a hard place in the thyroid. It almost makes the thyroid smaller rather than larger. You don't see a papillary cancer when the person swallows, any more than you see a breast cancer. Breast cancer, as compared with a fibroadenoma or a cyst, which gives a bulging, gives a contraction. And that's the way this is. The only thing that you can confuse with it is a subacute thyroiditis. And of course, this mistake should not be made because this is a clinical diagnosis. They don't have to be tender, though. But if you do think of it, the lack of uptake of radioactive iodine in a person who is not taking iodine is pathognomonic, and it's like taking out a normal appendix when you take one of these out. It's an error. The typical type of metastasis that we see in children with papillary carcinoma, the Delphian nodes and up the pyramidal tract of the thyroid, the mediastinal component, the jugular component, and there are also nodes all along the tracheoesophageal groove and the recurrent laryngeal nerve. Now, the classical neck dissection really gets only ordinary jugular sternocleidomastoid removal. And the commonest group involved is the paratracheal nodes up and down the recurrent laryngeal nerve and going down into the mediastinum. And this is why we prefer a high, wide thyroidectomy incision in women at least, or a hockey stick incision in men because there the cosmetic effect of the scar is not so important. We have almost never found it necessary to split the sternum to get these out. I think only once in our entire experience, because they're like a group of elephants. They hang on to one another, trunk to tail, and you get them started out and the whole group all come out. And in the papillary, they don't go any lower than that, although in the medullary, they do. The medullary keep going down into the mediastinum. And there, it might be worthwhile to split the sternum. But in the papillary, we've almost never had to. They can go to the posterior triangle, and of course, they involve this jugular group. The superior pole tumors go out along the vein to the jugular group, and the rest of the gland goes to the superior mediastinum. The recurrent laryngeal nerve becomes encased with tumor, but that can be separated. If you take your time, you can dissect that off, and local recurrences rarely take place. We use total thyroidectomy when there's bilateral disease, but we don't use it unless it is necessary. Now, almost all of the characteristic pulmonary metastasis of the papillary carcinomas in young people are endocrine dependent and will disappear, or at least will fail to enlarge at all when complete suppressive doses of thyroid are given. Once this regression takes place, it does not occur again. Now, it's an interesting thing that the regressions are better on the distant metastases than they are in the regional nodes, because in the face of thyroid, you can still get an enlargement of tumor deposits in regional nodes. But most of the enlargement in the regional nodes that occurs in these people in the face of thyroid is cystic. It's not cellular. The cells aren't dividing. It's just an accumulation of this brown fluid. So we don't have very much trouble with the distant metastases, but we do sometimes have to go back after nodes if you overlook one. We use no radioiodine in these people because we feel that the transformation which takes place from residual papillary carcinoma to undifferentiated cancer is enormously facilitated by any form of radiation. Almost all of the patients who have undergone that transformation have had some form of radiation, and since radioiodine doesn't completely destroy the majority of papillary cancers because there's so many papillary areas in it which the radioiodine doesn't reach, in the face of that information, we just feel that radioiodine is inviting trouble, and we have never seen a person who would respond to radioiodine, take up enough to do any good, who was not suppressed by thyroid feeding. So we always try thyroid feeding first, and have yet to see the person who progressed in the face of thyroid that radioiodine would help. Now, the encapsulated follicular or just a benign adenoma, and you can't tell the difference to look at it. This is the treacherous one. Angioinvasion would be the only feature to differentiate them. This type of tumor is not multicentric. You don't have to do total thyroidectomies on this. They're almost never multicentric. I haven't serial sectioned these glands. I don't know that you'd find any more multicentricity of the tumor in this case than you would in the normal thyroids that have been serial sectioned at the Mayo Clinic, because even there in the normal thyroids, just taken at autopsy from normal people, there were some 4% in whom there was histologic cancer. And you must remember the same thing is true in the breast. Gatch's work shows that normal breasts taken at autopsy show cancer in a high proportion of cases. And in the prostate, the same thing. 25% of people over 50 have histologic cancer of the prostate. So histologic cancer, multicentricity so-called, is nothing to be concerned about unless it is gross and clinical. The medullary, again, with its metastases, indistinguishable grossly from the papillary, and certainly demanding much more radical approach, because these metastases can be invasive of surrounding tissue, and again, these tend to be multicentric. And I think if anywhere in the thyroid, total thyroidectomy should be definitely considered in medullary cancer, or at least a total lobectomy, isthmus, and very radical subtotal on the contralateral side. And the characteristic undifferentiated cancer behaving in characteristic fashion within a month or two of thyroidectomy, fungating through the chest wall. These are much better done by needle biopsy rather than to attempt to remove them, because their average duration of life is only 3 months, And we have yet to see one which radiation would not control locally until the patient died of other causes. So even if they have beginning difficulty in breathing and swallowing, you still can irradiate them and hold them in check usually until they die of their other causes.
Our next speaker is Dr. B. Martin Black from the Mayo Clinic. He's professor of surgery there and head of section of surgery at the clinic. Dr. Black will speak to us on hyperthyroidism.
Graves' disease is a disease of unknown etiology, one of the facets of which is too much thyroxine. And all we do surgically is to take care of this too much thyroxine. Plummer's disease, by direct contrast, is simply too much thyroxine. The patient is cured when you take away this more or less autonomously functioning thyroid tissue. So it goes clinically. They vary tremendously. They vary tremendously in age, recurrence, practically everything down the line. Radioactive iodine became available in the treatment of Graves' disease in the fall of 1946. This did precisely the same thing, but in a different way, what thyroidectomy does. Thyroidectomy, of course, we remove most of the gland. With radioiodine, we destroy most of the thyroid. There was very properly a good deal of concern about the possibility of producing thyroidal cancer with the ionizing radiation. There was plenty of background that cancers could be produced by ionizing radiation. Most people in the United States decided that they would not treat younger people with radioactive iodine because classically the ionizing radiation-induced cancers required a period of some years before the cancers appeared. Most of us stopped at about 40 or 45, where radioiodine was used. Beyond this age, surgery still being used in younger individuals. By the mid-1960s, partly as a result of simply collected informal experience, but chiefly as a result of collection of much more formal experience on a very elaborate study and follow-up underwritten by the United States Public Health Service, and at a time when some 200,000, between 100,000 and 200,000 patients had been treated for Graves with radioactive iodine, it was perfectly evident the expected cancers weren't appearing. At that time, most people proposed that the age could be dropped down to perhaps 20 or 21 safely and without producing the cancers. Now, in the thyroid field, dating from 1950, there's been great fear of ionizing radiation on the thyroid glands of children and particularly of infants. This is thoroughly well documented. There's simply no doubt that it occurs. And for that reason, at this moment, we're still very leery about treating younger people. Now, I say younger people because it's not nearly so clear-cut that this ionizing radiation is so dangerous, let's say, in teenagers as it is in children below 10. But in infants and children below 10, no, so this constitutes still a stronghold for surgery. A second point where surgery undoubtedly is the treatment of choice is during pregnancy. Radioiodine, of course, easily crosses the placental barrier. You would radiate the conceptus if you gave the iodine too early, beyond the 13th week, 12th week, beginning the second trimester. The fetal thyroid traps radioiodine, and it can be devastating indeed. The thyroidal hormones are bound to the serum proteins, and if you destroy the fetal thyroid, the thyroid that you might give to the mother is indeed bound well to her serum proteins and may not at all cross the placental barrier well. You may not be able to treat the fetal lack of athyreosis by giving the mother thyroxine or T3. So pregnancy, indeed, is an absolute contraindication to radioiodine. Antithyroid drugs work very poorly, too, because you are producing, they are goitrogenic on the fetal thyroid, and, of course, surgery is the only modality that does not influence the fetal thyroid. I might say, because myxedema does develop after surgery, that if you do treat the mother with thyroidectomy, you'd better be awfully sure that she doesn't develop myxedema post-operatively. I suppose the other exception today where surgery is still indicated, the treatment of Graves, is in the large gland. There is some problems about radiation dosage beyond the usual dose limit used for Graves' disease. In the gland that we think has associated nodules, and in the block gland, certain iodine-containing compounds, of course, can prevent the uptake of radioiodine, which would imply a too large dose of the substance.
As far as myxedema is concerned, unfortunately, there doesn't seem to be too much choice between surgery and radioiodine. It would appear that after about 10 years, patients who've been treated effectively for Graves' disease with radioiodine have about 70% myxedema rate. The surgeons for a while thought we were doing much better than that, but as we've collected some data, it appears this is not so. The comparable figure in surgically treated patients after about 10 years is about 40%. So it's a matter only of degree, and I suppose it's true at the United States that the great majority of patients are being treated with radioiodine and will continue to be so treated. Now, in Plummer's disease, the other hyperthyroid state, there is simply too much thyroid tissue that doesn't function very effectively. There are large areas where there's no uptake of radioiodine at all. There are other areas where there's some mild uptake of radioiodine. The dosage of radioiodine is very difficult to calculate. The patient is not freed of his goiter. You have very little assurance as you examine the patient how much functioning thyroid tissue it really has, so your dose cannot be calculated nearly as nicely as with Graves', and surgery for that reason seems to be much more appropriate in the treatment of Plummer's disease than radioiodine. Very much the same statement can be made with the antithyroid drugs. It seems extraordinarily difficult to control the hyperthyroidism of ad goiter with hyperthyroidism with antithyroid drugs, even in dosage 3 or 4 times the dose level that work effectively in Graves' disease. So I think in conclusion it can be stated definitely today that except in unusual circumstances, the treatment of choice of Graves' disease is radioactive iodine. The treatment of choice of Plummer's disease, equally definitely surgery. Radioiodine is absolutely contraindicated in pregnancy and doesn't work too well when you have too large a thyroid or too nodular a goiter. This leaves finally the treatment of Graves' disease in children. As you know, Graves' happens very rarely in children beyond about puberty. Either method, either modality is effective. Both modalities are less good than they are in adults. After surgery, the myxedema rate is greater, the recurrence rate is greater. The risk, however, is not particularly greater. The difficulty of using antithyroid drugs in the children, radioiodine being out, is the necessity of giving the drug around the clock, the difficulty of getting the child to cooperate. In a series of our own, we started out with 16 very carefully selected patients, children, thinking we could treat their Graves' with radioiodine. At the end of the study, some 7, as I recall, had a thyroidectomy already. In only 4 had a remission been induced. I would say in the United States, it's possibly half and half. The internist leads toward antithyroid drugs, and in more surgically inclined institutions, it's to be surgery.
Thank you, gentlemen. And our thanks, too, to the University of Minnesota Nolte Center for Continuing Education for cooperation in recording and disseminating this material. And a reminder to you, Doctor, that your next issue will be mailed to you 3 weeks from now, rather than the usual 2, to spread your 24-issue subscription over the 52-week calendar. Audio Digest Surgery is produced and copyrighted by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association.